Hello, I'm Craig Walker, and I'm pleased to present to you the 3-year results from the MIMICS 2 study, studying the BioMimics 3D stent. Now, the BioMimics 3D stent is called by many the swirling flow stent. It is a laser-cut nitinol stent with a helical center line that has simple, accurate placement using standard delivery systems. And this imparts a non-planar curvature to stented femoral popliteal segments. This has been used in the P1 segment of the popliteal as well as the superficial femoral artery. It has improved biomechanical performance compared to straight stents, and there were no stent fractures noted throughout the entire MIMICS 2 investigational study. Now, the purpose behind this helical center line is that it promotes swirling flow. Now, why is this important? As we can see depicted in this aorta, well, swirling flow has been shown to increase wall shear stress on endothelial cells. Wall shear stress naturally protects against atherosclerosis and intimal thickening, and increased wall shear stress has been shown to provide an anti-proliferative effect after stenting without the need for a drug. Now here we see in vivo modeling of swirling flow in the stented segment. On the left, we have a standard straight nitinol stent. On the right, we can see the BioMimics 3D stent, and we can appreciate this swirling pattern of blood flow. Now, this is a very easy stent to place. It is a 6 French delivery system and an 035 wire-based platform. The delivery length is 113 centimeters. It is a pin-pull mechanism. We simply pin the center pin and pull back at the area of the stopcock here. It comes in 6, 7, and 8 millimeter diameters in lengths between 60 and 150 millimeters in stent length. It's coaxial over the wire. It's fairly easy to use, and it allows for very accurate stent placement. Now, the first in-man lead-in trial using the BioMimics 3D stent looked at some 76 patients after a roll lead-in study of 10 patients. 50 patients were randomized to have the BioMimics 3D stent, and 26 randomized to get a straight standard nitinol laser cut stent. And at 24 months, the primary patency in the BioMimics 3D stent was 72% versus 55% in the straight nitinol stent. And freedom from clinically driven TLR at 12 to 24 months was also superior at 91% versus 76% in the straight nitinol stent. Now, this was, of course, a relatively small study, but it provided the first clinical proof supporting the durable outcome benefit arising from the BioMimics 3D stent compared to a straight nitinol stent. Dr. Tom Zeller was the lead investigator in this trial. Now, since then, multiple trials have been arranged, and I'm going to present data from the MIMICS 2 trial, which has 43 sites in the United States, Japan, and Germany, which enroll these patients. These patients were followed for 3 years, and this study has been completed. But I want to point out that through these trials, more than 1,750 patients are being studied with this stent. Now, the MIMICS 2 trial was designed to evaluate the safety and effectiveness of the BioMimics 3D stent system in the femoral popliteal arteries of patients with symptomatic peripheral arterial disease. Primary endpoints were safety, looking at a composite of death, major amputation, or clinically driven TLR through 30 days, and effectiveness, consisting of primary patency at 12 months. Follow-up period was planned to be 3 years. 43 investigational sites enrolled 271 patients. In the US, there were 31 sites enrolling 162 patients. In Germany, 6 sites enrolling 78 patients. And in Japan, 6 sites enrolling 31 patients. And we can see the study's principal investigators. Now, this study had independent core labs for ultrasound, angiography, and X-ray looking for fractures. It had an independent clinical event monitoring committee and adjudication by this committee. The baseline patient demographics we can see were fairly similar to patients enrolled in other studies. There was a 2-to-1 male to female predominance. 45% of these patients had diabetes mellitus, 90% hypertension, 82% hypercholesterolemia, 81% were either former or current smokers, and 43.2% had had prior coronary revascularization of some form. Previous peripheral intervention, 98% of these patients had had none in the target vessel, and all of these had had none in the area to be treated. We can see that the majority of these patients were Rutherford category 3, with some being Rutherford category 2 and 4. There was only one patient of Rutherford category 5. The mean ankle brachial index was 0.7 in these patients. Baseline angiography and quantitative vascular angiography showed that the reference vessel diameter on the average was 5.2 millimeters. These were all de novo lesions, the majority being in the mid and distal superficial femoral artery. The average diameter stenosis was 78%, and the average lesion length, 81 millimeters. Totally occluded vessels were found in 30% of these cases. There was no calcium in 54% of the lesions, and moderate to severe calcium reported in 46% of the patients. 98.8% of these patients had one or more patent tibial arteries with less than 50% stenoses. Now, as we look at the BioMimics 3D stents that were placed, the majority of these received only one stent. That was 87.5%, with 12.5% receiving 2 stents. A total of 305 stents were placed in 271 subjects. The stented segment length was 112 millimeters. The diameter stenosis initially was 77.8%, and post-stent was measured at 12.6%. No dissections were noted in 98% of the patients, and type A through C dissections noted in 2% of patients. Device success, defined as being able to successfully deliver a stent to the area of interest, was 100%, and technical success was 100% in achieving core lab determined less than 50% residual diameter stenosis within the stented segment. Now, the primary endpoint was safety, and the composite of clinical events committees adjudicated major adverse events through 30 days, including death, any major amputation performed on the target limb, or clinically driven target lesion revascularization. And the performance goal, which had been set for this, was greater than 88%. And the achieved result was 99.6% freedom from major adverse events through 90 days. Therefore, the primary safety endpoint was achieved. The primary endpoint for effectiveness, looking at primary stent patency rate at 12 months, had set as a performance goal greater than 66%. And the actual percentage achieved was 73.1%. Now here I think it's important to talk about what was defined as patency. Patency was defined as no significant reduction in luminal diameter of less than 50% residual diameter of the lesion, or a less than 50% lesion within the vessel. Therefore, if one had 55% diameter stenosis, that was called restenosis. And this was looked at if ultrasound was used, utilizing a PSVR which exceeded 2. Therefore, many of these patients may have had what was considered non-patency without having even a symptomatic recurrent lesion. Now, if we look at the final results, the freedom from clinically driven TLR at 3 years was 81%. And we can see that at 1 year it was 89%, and it fell off relatively slightly thereafter. At 2 years, 84%, and at 3 years, 81%. Freedom from clinically driven TLR at 3 years, looking at lesion calcification, was followed in these patients. And we can see that at 3 years, there was no statistically significant difference between both groups. In the group that had no or only mild calcium, there was 78% freedom from clinically driven TLR. And interestingly, those with moderate or severe calcium had 82% freedom from clinically driven TLR at 3 years. Now, what about freedom from clinically driven TLR at 3 years in totally occluded vessels versus stenotic lesions? Once again, no statistically significant difference between the groups. At 3 years, those patients who had presented with a CTO had 76% freedom from clinically driven TLR, while those that had presented with stenotic lesions had 82% freedom from clinically driven TLR at 3 years. What about freedom from clinically driven TLR at 3 years based on the tercile of lesion length? Well, again, there was no statistically significant difference between the groups. Tercile 1, the shortest lesions, had 82% freedom from TLR at 3 years. Tercile 2, 81% freedom from TLR at 3 years. And tercile 3, the longest lesions, had 77% freedom from TLR at 3 years. So if we look at this and look at published reports from other trials, we can see that this stent did behave well. Now, it is important to understand these are not comparative studies, and the published data depends on many things. And so I don't think that we can draw conclusions from this other than to say that this stent performed relatively well. But unless we have a true head-to-head comparison, we cannot compare this stent exactly just from this sort of study to other cases, because it matters upon lesion length and it would require active controls. Nonetheless, I think this shows that the stent did perform well in this study. So as we look at the MIMICS 2 result with this highly flexible bioswirling stent, the data was reproducible with rigorous health quality data from the United States, Japan, and Europe. There was 81% freedom from clinically driven TLR at 3 years. There were 0 stent fractures, and there was accurate stent placement without the need for aggressive pre-stent delivery vessel preparation. Therefore, the MIMICS 2 study shows continuing benefit of BioMimics 3D at 3 years, even in fairly challenging cases. So in conclusion, BioMimics 3D is a promising stent which may reduce the burden of reintervention, improving outcomes, and lessening healthcare costs.